Epilepsy. Epilepsy is defined as a condition characterized by recurrent unprovoked seizures. At least two unprovoked seizures are required for the diagnosis of epilepsy. The seizures arise from the cerebellar cortex. Epilepsy is considered to be active if the patient has had seizures or had been treated with anti-epileptic drugs in the previous 5 years. It affects the temporal lobe. Identification of surgical candidates. Medical intractability. Recurrent seizures despite optimal treatment under an experienced neurologist for 2 years. Patient with lesional epilepsy, cortical lesions, for example, low-grade glioma or cavernous angiomas. Temporal lobe epilepsy, form of partial epilepsy, and one of the most frequently treated surgically. The most common type of extratemporal localization related epilepsy is that of the frontal lobe. However, 15% of the patients with partial complex epilepsy arising from other regions of the brain have associated mesial temporal sclerosis, that is MTS, and these cases are referred to as involving dual pathology. Causes of epilepsy other than mesial temporal sclerosis include developmental abnormalities, including focal cortical dysplasia, schizencephaly, focal polymicrogyria, macrogyria, tuberous sclerosis, neoplasia. Other causes include post-craniotomy, vascular malformations, brain injury caused by stroke, alcohol, drug abuse, or trauma, infections, for example, herpes and tuberculosis. However, significant proportion of epilepsy cases remain cryptogenic. Drug-resistant epilepsy is failure of adequate trials of two seizure medication schedules to achieve sustained seizure freedom, which might be monotherapy or in combination. The likelihood of seizure freedom from trial of a third medication is 5%. Objectives: establish the diagnosis, define the electroclinical syndrome, delineate the lesion responsible for seizure, evaluate the past anti-epileptic drug therapy, select ideal surgical candidate with optimal electroclinico-radiological correlation, and ensure the surgery will not result in disabling the neuropsychological deficits. Pre-surgical evaluation. The goal of the surgery is to identify an abnormal area of the cortex from which seizures originate and remove it without causing any significant functional impairment. Clinical features include nausea, visual disturbances, ictal behavior, that is blank stare, oral alimentary automatisms, and hallucinations. And in case of frontal seizures, we get bizarre, complex, rhythmic, and violent automatisms. Investigations includes MRI. The primary role is to locate and define the anatomic epileptogenic lesions. It depicts the relationship between the epileptic area and functionally important tissue. It is useful in planning placement of the invasive electrode. If findings concordant with non-invasive tests, invasive EEG is not needed. The second one is EEG. Interictal epileptiform abnormalities are a reliable indicator of a potential seizure focus. Focal interictal epileptiform activity spikes less than 70 millisecond, sharp waves 70 to 200 millisecond, or generalized spike and wave complexes. Then we have video EEG. These are prolonged recordings of simultaneous video and EEG to correlate the semiology of seizures and electrographic patterns. Provocative techniques. Sleep deprivation may be tried to trigger seizures in patients with complex partial seizures. Multiple seizures are recorded to ensure stereotype of clinical and electrographic findings. Both ictal and interictal data are analyzed. Functional mapping. fMRI detects localized events related changes in MRI signals. These changes are due to regional increase in the blood flow that accompany the neural activation and lead to paradoxically increased blood oxygenation in local vascular regions. fMRI compares blood oxygenation and regional blood flow at rest and during a task. Tasks can be used to determine language lateralization and predict language deficits after surgery. It is also used to map the blood flow changes related to memory, somatosensory, vision, and motor function. PET and SPECT. Ictal SPECT is performed after intravenous injection of the radioligand at the onset of seizure activity. Hyperperfusion of a discrete area is associated with the epileptogenic zone with an ictal injection. Interictal PET. Unlike SPECT, it is performed interictally. It demonstrates reduced regional glucose metabolism as measured with fluorodeoxyglucose in and around the epileptogenic focus. Neuropsychological testing, intracarotid amobarbital test, also called as the VADA test. This is applied to patients for whom elective surgery is being planned that possibly will involve eloquent cortex that involves memory or speech production. That is, patients in whom the left temporal or the frontal resections are being planned and who are strictly not right-handed. Primary components of pre-surgical evaluation. Detailed history and clinical examination to establish the symptoms, advanced neuroimaging, video or EEG monitoring, neuropsychological testing, assessment of psychosocial functioning. Major surgical questions to be asked are whether the seizures were focal or generalized, if focal, whether they were temporal or extratemporal, if the lesion is associated with seizures in present, functional deficits anticipated with the surgery. We have phase 1 and phase 2. Phase 1 is non-invasive and phase 2 is invasive. Under phase 1, which is non-invasive, we have clinical examination, neuroimaging, MRI, PET, SPECT, routine EEG, 24-hour intensive video or EEG monitoring, psychosocial evaluation. Under phase 2, which is invasive, we have epidural electrodes, subdural electrodes, intracerebral electrodes, and intracarotid amobarbital test. Palliative epileptic surgery. In patients from whom the epileptogenic zone cannot be localized, on when resection of the epileptogenic zone poses unacceptable risk, palliative options are considered. This include vagal nerve stimulation, corpus callosotomy, and responsive neurostimulation.